Discussion on the case of the Sixth Sense. We're going to discuss two films this afternoon, or actually this morning. We'll follow up the Sixth Sense discussion with an analysis of eye legend. Right? So, with regard to the Sixth Sense, where would you like to start? Anyone? Any particular character you want to be the focus of clinical attention? There's no wrong answer. Personal preference. So, Dr. Malcolm Crowe. All right. General question, what are some of the things you saw? No need to get technical at this point, just describe what you saw. Anyone?
I thought the interaction with his patient was really interesting. Just like, I don't know, like when he was trying to guess who he was, like it, but I don't know. And I guess I also like felt scared that like is that something that happens in psychiatry or like that you should be worried about? There's like patients coming to find you when they have like a grudge against you.
So a primary focus is this psychologist's relationship with one of his patients, right? I think the clinical term we would identify here is enmeshed, that there are issues pertaining to boundaries, and certainly the sharing of information that on a professional level should not have been shared. That also includes his going into the boy's home, as well as meeting him in other places and other areas that psychologists usually do not meet with their patients or clients. Right, it's a general sense. It's interesting that we have a character that does this after having just received an award from the mayor. That struck me as incredibly odd. So I agree with you, but yet it looks like his behavior, at least his practice in general, is being rewarded in a big way, nonetheless. And I wonder if there's anything to that. All right, so any thoughts about what appears to be a mismatch between behavior to be awarded and certainly behavior that I think the board would punish? Other than the perhaps the director and producer simply not understanding. I think that's the obvious here. But I think we can look at this as perhaps hypothetically being intended. And if so, then what might be some of the things that this group should consider is going on? Let's say that Dr. Malcolm Crowe presents to you as per recommendation from the medical board. What are some questions you'd like to know from him?
Why are you so close with your patients? How has that affected your personal life?
Why are you so close to your patients? Somebody else, try to put yourself in a situation or the situation of Dr. Crowe and reply with a potential answer to that question.
I care so deeply for them. I feel like I need to make sure like they're okay, they're children, someone has to protect them. Something like that.
I wanted to learn from the mayor, I would assume that he was doing this even prior to this.
Stop right there. Say that again?
I would assume he would be doing something similar prior to this.
Okay. What are you drawing that assumption on?
I guess I feel like he would get an award because he's doing above and beyond what he's supposed to be doing, what his counterparts are doing, and this seems like above and beyond what other psychologists would be doing.
That might be true. I could see that. But I also think there's a potential that what we observe in his interaction with Cole isn't consistent with past behavior, and therefore the award is coming from a good place. They're not awarding behavior consistent with boundary issues, because prior to meeting Cole, there were no boundary issues. And I think that's something to consider. Because if that is the case, then we have behavior in a main character that is a change from previous functioning. And you've heard me say this more than once. That is a hallmark of mental illness when that behavior impairs functioning. And this behavior impairs functioning. I mean, what he does is certainly directly impactful on his marriage. All right, so again, eluding the obvious and the big reveal at the end, if we're looking at this as a straightforward case in terms of the behavior to be analyzed and interpreted, this might be due to mental disorder. Especially now that we established that there's no way he could have had these boundary issues so significantly part of his practice when that practice received an award from the mayor. That's a possible alternative. And if we go with that, then we do establish that his current behavior is a change from previous functioning. And boy, have we captured a very important piece of describing a mental disorder. So that's something to consider here. Of course, the next question is, well, then what mental disorder might we be identifying here? So at this point, I think the next question would be the hypothetical of meeting with 99 undergraduate Rutgers students and polling them. They could choose A, a mood anxiety spectrum, or B, a psychotic dissociative spectrum. If you polled 99 undergraduates, A or B, what would they say? The Sixth Sense demonstrates in the main character, Dr. Malcolm Crowe. You guys want to chirp in on this one? Since you're two of the 99. This is behind the camera, behind the scenes.
I like how they say
A, all right, so you think that Malcolm Crowe is struggling with a mood anxiety spectrum, okay? So if that's the case, the next step would be to focus on what illness. There's always one illness. We have to arbitrarily choose from which to work. What illness should that be in the mood anxiety spectrum?
an adjustment disorder.
So adjustment disorder is possible. Anything else? And by the way, this is not film specific. This is every time we have a didactic like this. This is every time you formulate in psychiatry. So this happens tomorrow when you see a patient in your office. This happens next year when you admit a patient to your hospital ward. So this is the same exact illness you will choose, best demonstrative of a mood anxiety illness. So any other thoughts?
Bipolar.
Bipolar. Any other thoughts? Any other suggestions? Major depression. Okay, let's go with major depression. We all know the signs and symptoms that define a major depressive episode. Does Malcolm Crowe rule it? We've likely all learned these through the cardinal features of a depressed mood and loss of interest called anhedonia, with accompanying signs that fit an acronym CABs. That's how most of us learned the diagnostic criteria of a major depressive episode. Does Dr. Crowe meet these symptoms?
You could argue yes. He has, I mean, in the movie, we don't see, he probably has anhedonia. We don't see him really doing anything aside from work. We don't see him eat. We don't see him sleep. You can kind of extrapolate that he's feeling some kind of guilt towards maybe failing his previous patient.
Actually, I think that's enough.
right?
Again, in the real world, we know that the threshold is 5 over a 2-week period, demonstrating a change from previous functioning. But on shelf exams, if you get a patient that presents with anhedonia, poor sleep, poor appetite, and excessive guilt, and nothing more, and if your choices are major depression, antisocial personality, schizophrenia, and somatoform, I hope you're going to choose MDD. You're not going to leave that question blank saying, oh, it's not 5, so it's not MDD. We're looking for the single best answer. So we're going to play by those standards. And in that way, yes, I think Crow rules in. This is the time in our formulation that we identify that this condition called depression, major depressive disorder, is a diagnosis of exclusion. So now you're going to tell me, the group's going to actually tell me the 5 illnesses we must now investigate and rule out in order to rule in major depressive disorder. There are 5.
Hypothyroidism?
So due to another medical condition, such as hypothyroidism, good.
Substance abuse.
Good. A substance-induced mood disorder, that's 2. AK mentioned one before, bipolar disorder. And that's a great reason to start with major depression, because we address your thought in a 2-in-1. So we get a twofer by saying MDD, because in working up MDD, you automatically must work up a bipolar or related disorder. So that's 3.
Like trauma or recent stressors?
Actually, I'm gonna actually stop there. The question was posed wrong. It's actually 4. The 4th one that I usually like to talk about is bereavement, but that's more of a historical point, in that bereavement used to be an exclusion, but the bereavement exclusion has since been removed from the DSM. And I think that was important to bring up, because it plays a major role in our case formulation as much as it pertains to the 6th sense. So previous to 2013, and as of and including the DSM-4, we would have a discussion about bereavement with regard to needing to rule it out, but that is not the case today. Yet, you're going to find that bereavement is a big part of this movie. And I think that goes a far way in explaining the APA task force's decision to remove the bereavement exclusion. It actually plays out real well in our case formulation of the 6th sense. We're going to get to that in a little bit. Right? Does Dr. Crow demonstrate any of the other 3? Well, let's go by one by one. Is the 6th sense about a mood disorder due to another medical condition? Is there any overt evidence in the script that Dr. Crow is suffering from a medical condition? If you read the script, is it in there?
Probably not, unless like getting shot has caused him to be delirious.
So I'm gonna list gunshot wound. That's obviously a big part of this movie. So we're gonna keep it in our differential. And I think the question here, in as much as we're looking at mood and focusing on mood, is this an adjustment disorder with depressed mood, with the stressor having been shot? Okay. Now, again, in this case, the gunshot or the scene is probably important, but even in the context of how it may be influencing current behavior, it is more likely to be an adjustment disorder than it is due to the physiologic effect of the gunshot, unless they couldn't get the bullet out and it's leaking lead. Right? That's a consideration, right? But that might be low in our differential. All right? Is The 6th Sense a movie about a substance-induced mood disorder? Question: is there anything written in the script where we see this main character using or abusing a substance? No, I don't see it either. Okay. And then the follow-up question is, should the absence of that evidence in the script reassure us that therefore the sixth sense can't be about a substance-induced mood disorder? The answer is no. That is, the clinician should always maintain a high clinical index of suspicion. So we're going to leave it in a differential. It's going to be a little lower because there's no overt evidence, but that's okay because in real life, there's not always overt evidence, especially upon the initial evaluation. So we'll leave it in. All right, so here we are, that this movie appears to be a case study of major depressive disorder. We cannot definitively rule out the effects of a substance, and depending on whether the bullet has been left in, perhaps even an underlying or another medical condition. At this point in our case formulation, the clinician now looks at their note page and crosses off everything on their notes page that is explained by what we just discussed. And if we did this as an exercise, would there be anything left on your page? Because if the answer is no, we're done. We uncovered what the sixth sense is really about. If there is material left on your notes page, we have more discussion. Thoughts? For those of you following at home, I think this is the point where we might get to the big reveal. So spoiler alert. There is a major finding, clinical finding, if you will, at the end of this movie that may not be entirely consistent with our main character having depression. That is, we can keep depression as an Axis 1 diagnosis, but it looks like we may have to add to this when the big reveal becomes evident at the conclusion of this film. So what is revealed at the conclusion of The Sixth Sense?
He's dead.
It's that simple. So here comes Dr. Crow to your outpatient office with a chief complaint of, Doc, I've got this strange sensation that I'm dead. Right? You're gonna do what is usually referred to as a psychiatric review of systems. You're gonna ask about SIGI caps. You're gonna ask about dig fast, which are the DSM criteria for a manic episode. You're gonna ask about substance use, including the CAGE questions, right? The screening test for heavy alcohol drinking. You're gonna ask about anxiety. That's part of the routine H&P, the routine psychiatric evaluation. You're going to do that. But you're also going to have to address this chief complaint with regard to your clinical findings upon taking that history. So, what's going on here?
I'd ask if he feels like he said, I'd ask him like dissociative identity disorder or like multiple personality disorder, like an out of body feeling, or like what that feeling is that he feels like he's dead.
Yeah.
It might be a proxy for like feeling dissociated.
Absolutely. So that chief complaint is going to prompt an evaluation of the dissociative disorders, right? And you're exactly right. Now, I want you to notice something, and this is a major clinical pearl with regard to case formulation. Remember way back when I asked choice A, mood anxiety, or choice B, psychotic dissociative. If you had said psychotic dissociative, we would have done this first. Okay? So I think that the major teaching point today with regard to how to think like a clinician, upon hearing a patient's chief complaint, that patient being Dr. Malcolm Crowe, is that it doesn't matter which path you choose, because you're still going to get there, right? And when you think out loud, whether it's in front of a class or to a patient themselves, this type of critical thinking is what is called case formulation. And here we are. So it isn't that choice A was wrong. It's just the path that we chose to get to a discussion of the psychotic dissociative disorders, starting off with the dissociative disorders that now I think are going to comprise the very questions that we're going to ask this patient. Let's say that Dr. Crow denies any and all dissociative symptoms. I'm not sure how he would do that, but let's just say for teaching purposes, he does. But we are concerned about his belief that he is the walking dead. And we test the veracity of this belief, the intensity of this belief, because we want to make sure it's not a preoccupation/obsession versus a delusion. That is, how fixed is it? That is, how much insight does our patient have? If we actually rank or rate his insight 1 to 10, then it's likely not a delusion. But if we are going to rank or rate his insight as being a 0, then it likely is a delusion. If you were to ask him and probe his insight, what number do you think you're going to arrive at on a scale of 0 to 10? This is the sequel now. This is after he sees that ring drop. And a couple of days later, he comes to you. And you're going to now probe during a routine mental status exam insight. What number do you think he would be on a scale of 0 to 10? I'm going to give him a 3. So you think he has some insight?
I think maybe just I think potentially he could get insight because he's knowledgeable about psychology.
even psychologists and psychiatrists can become mentally ill.
Yeah, he seems pretty sure though, or he has a lot of evidence. I guess that's the thing, in his experience.
Well, I think let me make sure I phrase the question clearly. When I say insight, I mean that as a clinician, you are going to show him evidence that he is in fact alive. He is not dead. How rigid will he be in his thought that, no, I'm dead. I'm a ghost. And I'm forcing you to think like a psychiatrist. You're not allowed to think like a movie fan and interpret The Sixth Sense as a supernatural horror film. So my gut says that the insight's going to be 0. And I think we're dealing with a delusion that he's dead. I don't think it's a preoccupation. I don't think it's an obsession. Those two words are interchangeable at this point. The important thing is that neither of those clinical terms equal a delusion, which is defined by a total lack of insight. Preoccupations can be strong. They can be a 1 or a 2 with regard to the level of insight, or they can be weak. They can be a 9 or an 8 or a 9 when it comes to insight. But my gut says it's going to be a 0. I think we're dealing with a delusional disorder here. Now, there are 5 subtypes of delusional disorder. That is, there are 5 themes of delusions. What are they?
Somatic.
Grandiosity.
Erotomanic, good.
Paranoid.
Persecutory, good. Yep, same thing. So the acronym is JPEGs, and you got all of them except the J.
Jealousy.
Good. All right. Terrific. Unfortunately, the delusional belief that you're dead does not neatly fit into any of these artificial categories. So we're dealing with delusional disorder undifferentiated type. Now, fortunately, this has been previously described in literature. And as is with several of the undifferentiated types of delusions, we do have a name for this because it bears the last name of the neurologist that initially described it. So, single best answer, what is the Sixth Sense really about? And the answer is the Cotard delusion. That's a C-O-T-A-R-D. It comes up on shelf exams frequently as one of the undifferentiated types of delusions. So the diagnosis of Malcolm Crowe may end up being major depressive disorder and the Cotard syndrome. or more specifically, same exact thing, delusional disorder undifferentiated type. And if you're going to do that, then the Cotard syndrome should be in your formulation and assessment. So we're talking about the Cotard delusion, which is one of the specific unspecified delusions. The other ones that come up on shelf exams that are not necessarily portrayed in the sixth sense include the Capgras delusion. That's the delusional belief that someone, usually someone who you're familiar with, has been replaced by an imposter, otherwise known as the body snatcher syndrome. So any alien movie in which there are body snatchers is a metaphor for the Capgras or the Capgras delusion. And then the other one that comes up is the Fragoli syndrome, the delusional belief that someone can shapeshift and take the form of others. So it's a variant of Capgras. That's the Fragoli syndrome. And that's likely the agents in the Matrix, individuals who can shapeshift, so otherwise known as the shapeshifting syndrome. So the Walking Dead, shapeshifting, and body snatcher syndromes. 3 examples of unspecified delusions. Now, the other thing with regard to just putting a final bow on this as it pertains to Dr. Crow is that you can diagnose delusional disorder unspecified type, or if you truly think that the delusion is in the context of the major depressive disorder, you can identify it as Capgras syndrome within the larger context, within the context of a larger disorder, specifically major depressive disorder. So it can work both ways. You can identify it as a separate disorder and code it in Axis 1, delusional disorder and specified type, or as Cotard syndrome within the context of a larger disorder, specifically major depressive disorder. It works either way. Again, one way or the other, you have to determine whether or not it's due to depression, and in that way it would be a variant or an example of major depressive disorder with psychotic features. So that's the way you'd work that. Now, if you check your notes, is there anything left? I'm not sure there is. Any other thoughts here about Malcolm Crowe from the other side? No. Before we move on to I Am Legend, are there any other characters you'd like to discuss in the film?
I'm sure we can talk about the kid.
Yeah.
Cole?
Yeah.
Okay. Let's talk about Cole. Now, just full disclosure, when we talk about Cole, I would prefer to focus on maybe the family dynamics and what's going on and the role he plays, or the role the family dynamics impact him, rather than specific diagnoses for him, because I'm simply not a child or adolescent psychiatrist. I just think rendering a medical opinion or facilitating a case discussion about his diagnosis is really beyond the scope of what I'm able to offer, to be fair. Right. So we can talk about some of the things that interested you. I will tell you this, that, and again, further testament that unless you are trained in child adolescent, you probably shouldn't be rendering opinions on children this young, is the fact that the main character, Dr. Crow, totally misses the point when he dictates some form of childhood schizophrenia. Right. So that error, that medical error by the main character, is the exact reason why I'm not going to jump at the bait. But I think there's plenty going on in family dynamics to have a discussion. So, what interested you? What did you say?
Do you family dynamics by like between him and his mom, or like how other families brought him in with like?
Well, I mean, I can start out with regard to Cole. What did you say?
Cole lives in a single parent household with a mom that is working a lot, and
She seemed very distressed when she was like, Cole, like, tell me what you're seeing or tell me what you're going through. And not getting him to talk, and I feel like there's a communication disconnect a lot of times. Where the mother felt like really distressed because she couldn't.
She's overwhelmed.
Yeah.
She's struggling. There seems to be guilt pertaining to the death of her own mom, and certainly the absence of Cole's father, all impacting, as you mentioned, this single-family home. She works at least one job.
Yeah.
And certainly the picture is painted that she's overwhelmed and she's struggling. And what seems to be putting her over the top, that is the precipitant to whatever it is that she's experiencing, is whatever is ailing Cole, including perhaps not limited to, I see dead people. Right? So, and because of that, and because of her being a matriarch, or the matriarch, we could then begin to focus on Cole and his behavior and how that's affected. Because we do see certainly some things that even a doctor written into the script identifies. What is it that the physician observes? I think it's actually played by the producer, right? The role? M. Night plays it, right?
What he notices, like marks and bruises, scratches on Cole, and alludes that he's suspicious of neglect or abuse.
Yeah. Yeah, I think even dictates that they appear to be defensive wounds. All right, so I think that sheds a lot of light into the family dynamics, that there might be physical abuse. But he also dictates that he doesn't think it's the mother. So what might be going on here? There's two things I think we should consider as a group.
Self-harm or bullying.
All right, so that's number one, self-harm, in that the psychologist is just dead wrong and they're not defensive wounds at all. The other thing is that there appear to be two sets of wounds. The ones on his forearms and wrists appear to be defensive, and maybe he's right, but the ones on his torso and back aren't. So there's two sets, and we only hear the medical opinion of one of those. I don't know how, maybe he talks, I'm sorry, I think I have it backwards. Maybe he thinks that the wounds on his wrists are not defensive, but self-inflicted, but the others are defensive. We just don't hear the full story in terms of the full dictation. In that case, Dr. Crow should have been just a little bit more specific about which wounds that he was identifying. There's a reason why on the ER chart, there's usually a picture where you draw in the wounds, right? It's the exact reason why. So that might be going on, and we only have half the picture with regard to Dr. Crow's perspective. All right, so let's just talk a little bit about the defensive wounds. If not the mother, then who? You said maybe bullying. That's certainly, I think, a theme in this film. That's a significant possibility. Any other? Sorry?
We had mentioned self-harm.
But before we get there, yeah. Let's talk about the defensive wounds first. Remember the pertinent negative. We talked about this in other films. Who is not scripted in this film? Yeah, his father. Exactly right. Again, when normal people go to the movies and watch The Sixth Sense, there's not much to discuss about the dad. He's unscripted. When people who rotate through their psychiatry clerkship or take an internship in the Department of Psychiatry at RWJ Medical School, you have to watch movies differently. People who are unscripted are just as important as people who are scripted. And I believe the father plays a much larger role in this movie than what normally would be indicated. And that's paralleled to our patient's history. I mean, if you're meeting someone, let's even say in psychotherapy, and they haven't mentioned a particular family member in a couple of sessions, in your initial sessions, you're not going to sit there and simply dismiss that, right? That's very telling. Your patient's telling you in a nonverbal way that this person might be playing a central role in the reason they're in therapy. Right? So there's a parallel here. And we wouldn't want to ignore this unscripted character. He may have actually come back to Philadelphia, and he may, in fact, have met up with Cole again. And those non-defensive wounds may be an indication of that. It's not something that we would ignore. How about the defensive wounds? I'm sorry, the the self-inflicted, I'm sorry. I'm getting confused with them. I apologize. The self-inflicted ones.
Maybe he's doing it for attention because he feels like he's not getting enough at home.
Could be. Right. Could be. Could be some secondary gain there. Anything else in a differential?
A consequence of whatever psychiatric condition that they might be considering.
What are you thinking about there? Yeah.
For example, if he's having like visual auditory hallucinations, you might think of harm as like a way, as like, oh, they're telling you to do that, like command hallucinations, something like that.
Could be. Anything else? The concern I would have here, and of course, this is something that we would need to ask the individual, and maybe not verbally, maybe non-verbally through play therapy, but we would need to get to a trauma history. Because if Cole has a history of trauma, the hypothalamus has three basic choices: fight, flight, and freeze. And if Cole was put in a situation where fight or flight was not an option, then freeze may have been the option, meaning dissociation. That the trauma, either because of who it's coming from or the intensity of it, or both, was something that he would not allow his conscious awareness to take part in. So he dissociated, which happens, right? Freeze. That is a function of the hypothalamus. Unfortunately, if the memories are not registered around the time of the trauma, if he does not get treatment at or around the time of the trauma, he can dissociate in the future, months, years later, decades later. So what may have been adaptive during the trauma itself becomes maladaptive in the focus of clinical attention later on, and perhaps even in the context of what might be called acute stress disorder initially, and then even post-traumatic stress disorder thereafter. Individuals who have that sense of numbness or freeze, in this case, read freeze, may cut themselves to get out of that. And that's one of the questions we would need to address with Cole. At his age, not likely directly, but some way indirectly. Again, through a trained professional. So that's a concern I have. Any other thoughts about Cole? Any thoughts before we leave this character, perhaps this film, of how in the world is he able to tell his mom things about his grandmother that only his grandmother and mom would know? You're not allowed to say that his grandmother's ghost visits him at night, because if this presented to you while you're on call at 3 a.m. in the morning, and if you called me as your backup faculty, you are not going to be allowed to say that. Actually, if there's one attending who would allow you to say that, it's probably me. I think it's further evidence that his father isn't back in town. Right? Because, I mean, his dad would know. So I think it supports the conspiracy theory that dad has returned, his perpetrator has returned, and that's why we see the escalation of symptoms in this child. Whatever diagnostic label we want to use, that's what might be going on here. All right, let's switch gears a little bit and jump over to another genre within horror, the zombie. So, any particular character in I Am Legend you would want to focus on?
The main character.
So, Dr. Robert Neville. Okay, so again, what did you say? And we're not going to go through the actual strict algorithm that we applied to the Sixth Sense because I think now, I mean, especially since we just did it, I trust that you know how to do that. So for reasons for our time constraints, we'll just discuss this character a little bit more in a little bit more non-structured way. But what did you say?
He's a very isolated individual. His only companionship is a dog. We see that he's speaking to mannequins as if they are real living people.
So let's go to the initial scene where we're first introduced to this dialogue. Thoughts?
The dialogue with the people, you mean, the mannequins?
The mannequins, yeah. In that initial scene.
At first I thought it was just like playful, like he was just having fun, because he was like bored and trying to just play pretend like it was just regular life. Like it was a way to keep himself sane. That's how I interpreted it at first.
Tell me more about trying to keep himself sane.
Like he seems to have these like rituals that he does. Like I was like, whoa, he's working out when it's like the end of the world, you know, and like, he's like trying to keep some semblance of like normalcy.
So draw the connection between keeping some semblance of normalcy and remaining sane. Well, what's the connection there? And is there a parallel that we see in clinical medicine?
It's a coping mechanism for him.
Go on.
In terms of if, like denial, if nothing is wrong, then he doesn't acknowledge like that things are wrong, then therefore they must be okay.
I think the observation that this is a product of denial is something that the clinician must consider. And I think that we should get to more of a discussion of that. I absolutely agree with you. Remember, when we observe human behavior, no matter how odd or bizarre it looks at first glance, I think it is best practice to accept that this is normal until proven otherwise. And even though the proof of otherwise might be instantaneous, the clinician should train their brain to always give the individual the benefit of the doubt. It's just a great way to practice. And in this case, I think you're right, that this is normal. So our starting point, I think, is our ending point when we begin to analyze the initial scene in that video store. What Neville understands is that every single social cue that has ever governed our behavior and provided structure to our day is gone. Nobody's ever telling him again when to get up. Nobody is ever telling him again when to eat, rest, work, or even go to bed. So if in the absence of those environmental cues, he just did whatever he wanted, he also knows that his biological rhythm, circadian rhythm, will break down. And this is where the denial comes in. If he is under the belief that his cognitive awareness and executive functioning is what separates him and gives him an advantage over the zombie apocalypse and the zombie horde, then to lose that advantage means sudden death. That's why he's talking to mannequins. That's why he uses an alarm clock when he is the last man on Earth, taking that from the previous movie's title. I mean, none of us would consider using an alarm clock when there's no reason to get up. ever again. But he knows better. The parallel here is delirium. When people begin to lose that day-night diurnal variation, that internal clock, they can become confused. Which is why when we first address acute confusion in the hospital called delirium, the initial assessment includes, quote unquote, the delirium protocol, right? Bringing things in that are familiar, making the room light during the day and dark during the night, limiting ambient sounds, familiar objects at bedside, pictures, things from home, right? Frequent reorientation, providing that structure, that superstructure to limit the confusion. That's what he understands. So he's doing it in a primary preventive way, but that's why he's doing what he's doing, including, but not limited to, talking to mannequins. So again, a nice review with regard to the proverbial delirium protocol. He's employing that. But then things seem to change. All right? So describe to me the scene where things seem to change with the mannequin.
There's one scene where he's like driving along. He's like, "Father, are you real? Are you real?" Like he seems very agitated, like and not knowing. I don't know. There were a couple of scenes with mannequins I feel like things changed with this one where he seems like very disturbed by.
Yep.
I don't know.
And his becoming disturbed, and to the extent he is disturbed, directly leads to him getting trapped. Right? He's ensnared, which directly leads to his dog getting bitten and infected, which directly leads to his having to kill his dog, which directly leads to a suicide attempt. So that is the turning point scene in the entire movie. Right? Him seeing Fred outside. And I believe that the way he acts or reacts has everything to do with denial. Because up until that point, he utilized this defense mechanism that, like all defense mechanisms, aim to distort reality. His id impulse is that he is going to die. I mean, it is tens of millions, over 100 million to 1. He's going to die. He is in denial about this because this zombie horde actually has executive functioning. They can plan. And you could hear him, if you listen close enough, you pay attention at the beginning of this movie, dictate that they can't. And that's the advantage he has. That is complete denial. And that denial is chipped away at. And he's made to face reality at the time that Fred is outside of that video store. Because upon that sign, he realizes that the zombies have set a trap for him, which means he's dead. So denial no longer works. So he resorts to a secondary defense mechanism called acting out. And we see the way he has this observable behavior that is acting out towards the mannequin. Unfortunately, that defense mechanism, that secondary defense that he employs, is maladaptive to the extent that he steps into that snare trap, leading to his dog getting bitten and infected, leading to his having to put Sam down, leading directly to a suicide attempt. That's how the case formulate what's going on with Dr. Robert Neville. Denial, made to confront reality, secondary defense acting out, suicide attempt. Now, the other thing I think that connects the acting out to the suicide attempt is his having to put his dog down, because Sam represents the last and final remaining link to his daughter. So having to kill Sam makes him relive his guilt that he killed his daughter. And that's just too much to bear, hence the suicide attempt. There's another reason why I wanted you to watch I Am Legend. And this connects back to the Sixth Sense, at least what we talked about regarding the Sixth Sense being a case study of major depressive disorder. And that is focusing not necessarily on Dr. Robert Neville, who, by the way, I believe is depressed. So I do believe he shares a diagnosis with Dr. Malcolm Crowe. Two doctors, two cases of depression, two different movies. But I think more importantly, for purposes of connecting these films even more and getting at the etiology of their depression, is to focus not on the physician, but on the zombie horde. Talk to me about the zombie. Like him, hate him, love him, what do you got? No opinion on the zombie?
I guess I felt, so the zombie scene, where he's very up in his lab, and, I guess I felt like, that was the first time I felt, like there might be more to them than just these aggressive people, because they tried to save this woman, and it turned out they were in love. So, I guess I felt kind of like sad for them, like they were just people who got infected, and like maybe they could change, like they weren't, when you tried to talk to them, there were a couple times when they seemed responsive to like discussion, I don't know.
That is a major point here. For decades, we understood the zombie to be the undead. They operated in a universe, in a plane that was neither the living nor the dead, otherwise referred to as the undead. They were very similar to vampires and skeletons. Right? That's the undead. With regard to I Am Legend, they're no longer undead. And this really changed about 1954, where the zombies became humans, but infected. So certainly a change from previous functioning. Now again, in previous zombie films, the new functioning did include memory deficits, impaired concentration and attention, difficulty with executive functioning and planning. That was true, but not with these Darkseekers. And more, as we modernize the zombie, we learn more about their humanistic characteristics, or their humane characteristics. And a lot of who they were still comes out in their being a zombie. That's a trend that we've been seeing. So we've moved from the undead, previous to 1954, to the infected monster that has no recollection or memory, no brain function that would allow anybody to attach them to a previous life, to now some semblance of their having been human, and that there might be still somebody in there. That's the evolution that we see, and certainly one that's picked up in this movie. What caused the zombie apocalypse? By the way, the zombie apocalypse, as it was described and depicted in the 2007 I Am Legend, is very similar to the original description in William Matheson's book, I Am Legend, in that it was referred to or described as a vampiric plague. So it was a combination of vampire and zombie. Right, so most current adaptation loyal to the original novel, vampiric plague. But I'm going to just refer to them as zombies. Right, so what do you got?
It's like a genetically modified virus.
Yeah. Right. And the idea here was to inject the virus into people suffering from cancer, with the focus on initiating an immune response in cascade that would then cure cancer. Right? That was the idea. But something goes awry. That is, the immune system misamplifies. Specifically, it just does not shut off correctly. And we see this in real life. We see people getting an infection, and then the focus of clinical attention, maybe even in a medical intensive care unit, is to focus on the maladaptive immune response days later. And that results in our adding immunosuppressives to treat someone who was admitted and perhaps even intubated for infection, which I think on the surface seems counterintuitive. Why steroids? Why prednisone? Why other immunosuppressives when the individual is infected? And the answer is because we have to dampen the immune response because it did not shut off correctly. We saw that with COVID too, right? Immunosuppressives. And that's what happened here with the zombie apocalypse. The immune system was attacked in such a way that it created the zombie. And we do know that there are aspects of the zombie that are directly attributed to this maladaptive immune response. More specifically, tryptophan being catalyzed by IDO to a neurotoxin called quinolinic acid. QA is neuroexcitatory. It does agonize, that is, it binds to and activates, it acts as an agonist at the MDMA receptor. And as a result of that, we see the zombie. We see significant irritability and agitation. We see evidence of sleep disturbance, diurnal variation, perhaps a change in their circadian rhythm. Not necessarily in this film, but certainly in previous films, a significant change in appetite where zombies eat brains. In this case, we see significant psychomotor agitation. In previous zombie films, again, I'll take you back to, was it 1967 or 1968? With regard to George A. Romero's Night of the Living Dead, significant psychomotor retardation. They were slow walkers, as is The Walking Dead. So there's a lot going on here with regard to the immune response, resulting in those very characteristics that define the zombie. If the infection, and more specifically the cytokines, in response to the infection, don't catalyze the reaction from tryptophan to quinolinic acid, where then might the actual equation go? That is, what is another potential product of tryptophan, especially in the absence of centrally mediated cytokines? Exactly. Right? So the buildup of quinolinic acid is certainly something that is inversely proportional to CNS serotonin. And along the same way, if we were to think about this reaction, can lowered serotonin levels result in irritability, change in appetite, change in sleep, psychomotor retardation, or agitation? And if that's the case, what might be the single best diagnosis? Yeah, right. The zombie serves as a near perfect metaphor for major depressive disorder. Therefore, any zombie film you ever watch, you should look at it through the eyes of a psychiatrist as a metaphor for MDD. And in Neville's case, a character with major depressive disorder, you have a case study of a fictional character suffering from the illness MDD, who is fighting or operating within a zombie apocalypse, itself a metaphor for the etiology of major depressive disorder, specifically the immune system's role in depression. And if you look up any articles of immunopsychiatry, you will see the role that cytokines play in the misamplified immune response, the lowered serotonin levels, the increased quinolinic acid levels, as being the origin of major depression. or the zombie. I tweeted yesterday that there's an animal model to this as well. I posted that on my Twitter page yesterday with regard to an infective agent leading to programmed behavior that is a change from previous functioning. So that's up on my Twitter page. Any questions about I Am Legend? Any questions about the Sixth Sense? All right, we'll leave it there.